Okay, good evening everyone and welcome to this meeting of the London Borough of Newham Health and Adult Social Care, Air Quality and Equalities Scrutiny Commission. Can everyone present hear me? This evening's meeting is being held at East Ham Town Hall. Members unable to join us physically at this location are able to join remotely. However, they will not be able to vote and their attendance won't be officially recorded, although their virtual attendance will be noted in the minutes. I'd like to welcome members of the public and press who are physically attending or watching on YouTube. With regards to the meeting etiquette, members of the council and invited contributors, please can I ask that you indicate you wish to speak by raising your physical hand or by using the hands up symbol on the Zoom dashboard, and hopefully Roger will sort of keep an eye on the virtual hands just to alert me if anyone's indicating, but they're not on my screen. And for this meeting, as I've already mentioned, we have Roger Raymond present to advise on protocols and assist with the technology. This meeting of the London Borough of Newham Health and Social Care, Air Quality and Equalities Scrutiny Commission is now called to order. So I'd like to start by getting the Commission members to introduce themselves. So I'm Councillor Susan Masters, Councillor for East Ham South and Chair of the Commission.
I'm Councillor Joel Aguda, Councillor for Plaistow North.
Councillor Rita Chudder, Councillor for Canning Town North.
Councillor Houghton Verde, Bowling Ward.
And on the Zoom, we've got Councillor Arik.
Councillor Arik Chowdhury, Canning Town North.
Councillor Bagoom. I think at one stage. And
I'm Councillor Mohammed Ghani Bolin.
Fantastic. And have we still got Councillor Bagoom, or have we she drops off? She might be having problems with connection. Okay.
I'll keep an eye on if she was here, but I'll.
So our first task in the new scrutiny year is to elect a deputy chair for 2023 to 24 who can act as chair in my absence or other matters relating to the commission agreed. I move the nomination of Councillor Rita Chudder as the deputy chair of the commission. Is there a seconder? Councillor Joy Laguda. Can I have a show of hands to agree the nomination? And as stated before, it will only be people, members present in the chamber who can vote. Fantastic. So the nomination of Councillor Chudder has been agreed. Welcome as my deputy.
Thank you.
Do we have any apologies for absence? I've had apologies from Councillor John Gray and Councillor Femi Falola. Are there any other apologies? The other thing I should mention at this stage is owing to an extraordinary away day, we will not be joined by Jason Strelitz tonight, nor Councillor Whitworth when we get to the air quality item. And I've also had apologies from Councillor Wilson and Councillor Khan for tonight owing to illness. Item 4, are there any members wishing to make a declaration of interest?
Chair, can I declare that I'm a trustee of the London Air Ambulance? Whilst it's not pertinent to this agenda, I just think just in the interest of transparency.
Okay, so that's been recorded. The next item we have are the minutes of the meetings held on the 9th of February 2023 and 14th March also 2023, which all feels a very, very long time ago. If anyone can sort of still remember any sort of difference between what occurred in those meetings in the minutes. I think now. And I know there are some actions outstanding, so I've asked our officer to sort of look into those. So can I move then that the minutes are a correct record of those two meetings? Do I have a seconder?
Yes.
Thank you, Councillor Laguda. And the minutes agreed. Fantastic.
Councillor Bacon's waiting in the waiting
room. Can we admit Councillor Bagoon, please? So the next item concerns our new work programme for the new scrutiny year. The Commission's already begun the development of its work programme for 2023 to 24. We've held 2 informal meetings of the Commission, in addition to the many conversations I've been having over the last couple of months with system stakeholders. The work programme is attached for further discussion. And I'd just like to make some opening remarks about its composition and rationale. So we know that over the next 10 years, Newham will see further increases in population, currently estimated at a growth of 21.5%, or a further 76,000 residents. We also know that this will include an increase in our proportion of residents aged over 65, and that it will disproportionately affect the north, northwest, west and south of the borough. Over the last year, we've learned about the lack of availability of NHS dentistry and our shortfall of GPs. We've also seen challenges to acute capacity, formerly referred to as winter pressures, become consistent all year round pressures. At the same time, we know that all parts of the system are experiencing budgetary challenges, whether this applies to delivering business as usual services or carrying out the kind of transformations to services we all agree are required. Changes that will rebalance our system towards prevention, make more room for our community, voluntary and faith sector, and address the inequalities we see in health outcomes. To this end, it's unsurprising that there was an overwhelming interest in examining Newham's prospects within the new North East London system. Do we and will we have the resources we need both to improve local health outcomes and to address our inequalities? This will be a theme featuring in all our meetings in the new municipal year or sort of new year. And as we're supposed to be a system, we've not taken the usual approach of looking at one part of the system in isolation in each meeting: acute care, primary care, social care. Instead, each meeting will look at a different area of healthcare, emergency, elective and urgent care, say, and then look at how the system proposes to address it across all partners. We'll consider whether the present models are the right ones, funding and funding formula sufficient, and what might need to change. Our focus on inequalities that framed last year's work programme will remain as a golden thread through all meetings, alongside an eye on the role and impact the private sector is playing, both positive and negative. Alongside this, we plan to focus on specific pieces of work we're undertaking as a council, contributing to the development of the next stage of the 50-step public health strategy, considering how far our ageing well strategy has improved the experiences of ageing in Newham 1 year in. We'll also hone in on particular areas of concern, like how type 2 diabetes levels are being managed, say. But as ever, we'll ensure we hear from residents and our community groups alongside statutory health partners. Outside of this, our scrutiny has 2 new areas to its remit. In September, Newham's Cabinet Deputy for Equalities will be introducing us to the Council's wider work in that area. Later on in this meeting, though, we'll be hearing from Newham's air quality team about the impact of poor air quality on health and how they propose to address this. Finally, nobody can accurately predict what health issues might emerge in the next 10 months. So we'll hold the first half hour of our meeting to be a standing item on emerging issues, recreating our flexible floor for any partners to inform on developing challenges in the borough. Thank you. So I'd like to ask now whether the committee agrees the work programme as designated after discussion in this meeting. People would like to vote to agree it?
Agree.
Fantastic. So that's the work programme agreed. Thank you very much. So now we move on to the substantive items of this meeting. And item 7, our standing item update on pressing matters. Now, before we get on to the main part of this meeting, which will be looking at the Metropolitan Police's decision to stop responding to requests where there's not an immediate threat to life, there were just a couple of questions that members of the Commission wanted to pick up. So I'm hoping that partners will have answers, and if not, we're very happy to accept written answers outside of the meeting. So Councillor Chowdhury, I know you had a couple of points that you wanted to raise. If you sort of make them one at a time and we sort of invite answers from the stakeholders on the Zoom, that would be brilliant.
Sure, thank you. So my first question is, are colleagues aware that there are some GP practices in Newham which are advising patients to call a premium rate number instead of a free phone number? And if so, are there any mechanisms or efforts to try and combat this move towards premium rate phone numbers for GPs?
Do we have anyone on the call from primary care can Marie or Joe maybe from the integrated care system answer that? Joe, you've got your hands up.
Yes, I have. Yes, I can't. I wasn't aware, so I can't give a full answer, but I will take that away and come back with a response.
Fantastic. And Councillor Chowdhury, you also had a question about the impact of the strikes.
Yes. So what has the impact of the recent junior and senior doctor strike been on waiting times and general health service provision in Newham?
So I think that's a question for Simon Ashton as manager of the hospital about the impact of the strikes at the moment.
Thank you, Chair. My name's Simon Ashton. I'm the Hospital Chief Exec at Newham. In terms of the impact of both strikes, so over the course of last week, we had the junior doctors strike, then we had a short break, and then we had the consultant strike Thursday and Friday. There was no impact in terms of internal hospital discharge and assessment of patients and emergency care and intensive care. But the real impact came from the fact that we had to significantly reduce our elective work. So that's work where we operate on patients or see patients as outpatients. So those programs of work were significantly reduced because of the last week, because we had to provide those doctors to support emergency care in the hospital. Now, overall, in terms of overall waiting times, that hasn't made a material difference to the overall waiting times of patients. But of course, there will be a fairly significant disruption to patients who had appointments, who would have had to receive telephone calls to cancel their appointments and reschedule as soon as possible in the coming weeks. So whilst overall waiting times won't have been impacted, there would have been there's quite a lot of turbulence around cancelling and rescheduling patients' treatment.
And do you have any numbers, Simon, in terms of the number of appointments that had to be cancelled?
I could supply that after the meeting if helpful.
That would be really helpful. Thank you very much. The other matter I wanted to consider before we move on to our main topic of conversation in this section of the meeting is measles. We're aware that there's been a spike across London, and we were just wondering whether this has been reflected in Newham. Is there someone here who can answer? I think Claire Gresham from the public health team, were you going to answer that one?
Yeah, I am. I'm also just to say, I can't seem to rename myself as co-chair. I think it's from a previous meeting, so apologies. So actually, in terms of the data, I haven't been informed about any particular spike in cases in Newham, but I will need to double check and confirm that in case anything's changed since I was last updated. But I can provide, if it's helpful, a brief overview of the action we're taking in Newham and the numbers that we need to vaccinate to get up to the target.
That would be helpful.
Okay, so very briefly, there's a national concern around measles, but there's a particular concern about London. The target for MMR vaccination is 95%. That's the level needed to protect the whole community from getting from measles spreading. In Newham, and most people are vaccinated when they're children, and it's part of the routine immunisations that GPs provide to children. And generally speaking, as part of the routine service, if children haven't had the vaccine at the sort of the recommended time, there are catch-up vaccines offered through schools as well. So in Newham, our vaccination rates are around 88% at age 5, which is in line with the North East London average. So we're sort of similar to lots of North East London. And what that means is that we've got a relatively small way to go to hit that 95% target. And what that means in terms of numbers is around 250 children in total. There's been a lot of work behind the scenes in the NHS to make sure we have good data sharing. So what we've now got in place is a list of individuals who have not had the vaccination, and Vaccination UK have been commissioned by the NHS to contact those individual families directly and invite them to come forward for vaccination. So that's what's going on at the moment, and so we'll be getting data updates to show how many of those 250 have since been vaccinated to reach that 95% target. So that's a summary. There's more information if it's helpful around other comms and outreach activity, but the kind of the thing that's going to make the most impact is that direct contact with families. And I think, you know, we're quite optimistic about the fact that we know that direct contact works, and we'd have a relatively small number of families in Newham to contact. So we'll be able to update in coming months on how that campaign has gone and where we've got to as it rolls out.
Okay, do I have any questions from the Commission? Councillor Laguda.
You know, there's been a lot of vaccination hesitancy, especially during the COVID. Has that extended to the children at all? Because a lot of a lot of mothers are very hesitant to have the COVID. Do you think that has had an impact on the children getting vaccination?
So we haven't seen a significant dip in children getting vaccinations since COVID. So what we can see from the data is that we're sort of we're roughly in line with other areas. So I wouldn't say there's a significant difference in Newham in terms of comparing ourselves to others or compared to previous years. It's hard to say, and I don't have a definite answer to hand about whether COVID has had any impact on people's willingness to get vaccinated, but our levels are quite similar to how they've always been.
Okay, Councillor Chada.
On a slightly different but related note, I notice there's a lot of public education at the moment around shingles. Is that a specific area of concern that we should be worried about in Newham?
Not that I'm aware of, but someone else on the call might have more to say on that.
Joe, you're looking. Yeah, you're not aware of anything in Newham. Well, that's
Not specifically, no.
Okay, is there any way we can just sort of look and see whether there's been any kind of sort of spike in cases and whether it's sort of affecting any sort of communities in particular? That would be really helpful.
I mean, just drawing on the fact, Chair, that there's a national campaign. Obviously, that's been prompted by something. It'd be just useful to know if there's a local angle to that in any way.
Fantastic. Okay, we'll look into that and sort of bring some information. Councillor Laguda.
There's been a lot of publicity about older people having shingles vaccine. So I think, one day I went for my shingles vaccination and the whole surgery was full. So I think there's been a lot of publicity about people having shingles vaccine.
Okay.
I was going to say no, but then somebody said, go and have it.
Okay. So we'll look into this and bring some sort of data back to the next meeting. So has anyone got any other questions on measles, or should we move on to our next item?
Yeah, just a quick question. Are there any particular communities that are more vulnerable, which we need to keep a lookout for either measles, or could be anything really? Because you mentioned shingles.
Yes.
And I understand I've been to the surgery as well lately, and it's been there quite often. But similarly, there are some, like measles, for example, there might be some communities which are still not up to date with what's going on. So do you think that we need to do some extra work on that or try to identify them?
So in Newham, we are vaccination is the number one intervention that protects people against measles, and we have, in terms of uptake, it's relatively even. So we don't see, compared to some other places, there's not one really specific community or cohort that hasn't had the vaccination. So that's not to say there might be slight differences between different parts of the borough or different communities, but generally speaking, we don't see, like, you know, very clear specific cohorts of people that don't come forward for the vaccine. So generally, so thinking about the current campaign, the approach is very, very targeting those specific families that haven't had it, which is relatively sort of dispersed around the borough.
That's really helpful. I think I'm going to sort of move us on to the next item, but if we can have some data back to the next meeting, that would be really helpful. And it's reassuring that there don't seem to be any particular sort of inequalities in vaccination uptake. So back in May, it was reported that from September, the Metropolitan Police would only attend requests involving mental health crisis where there was an immediate threat to life. I thought it would be really helpful in the section of the meeting where we look at emerging issues to look at the impact of this decision alongside a more general consideration of the facilities and resources the police have to support people in mental health crisis. Now, we did touch on this a little last year when we were sort of looking at inequalities and mental health in general, but now there's been this sort of extra announcement. It felt like a really good time to sort of bring it back to the committee. So for this item, I'd like to welcome Jo Fraser-Wise, Interim Joint Newham Director of Delivery, NHS North East London. Do we have Marie Truman able tonight? Okay. Bailey Mitchell, Borough Director, East London NHS Foundation Trust. And we've been joined at East Ham Town Hall by Michael Jones, Senior Programme Manager for Community Mental Health Transformation Programme at East London NHS Foundation Trust. I'm hoping we've also been joined by Lynn Benjamin, Operations Director for Mind in Tower Hamlets, Newham and Redbridge. Detective Sergeant Andrew Barry, Mental Health Representative representing North East Basic Command Unit for Waltham Forest and Newham Police. And also I'm hoping that we're being joined by Antonio Ferreira, founder of the campaign Hear Me Speak, that seeks to strengthen legislation, guidance and training around policing in a mental health crisis. Roger, are all those people on the Zoom at the moment?
Yeah, they're all here.
Fantastic.
Would it be possible to ask those individuals to just turn their cameras on?
Yes, can I just sort of ensure that all those people have got their cameras on for this item? Fantastic. Welcome all of you. We really appreciate you taking the time out of your day to come and join us. So, as I said, last year, this committee was pleased to welcome the police to our discussion of health inequalities and mental health. And tonight I was wondering if we could start off, if we've got Sergeant Barry on the call, to actually sort of set some context to this announcement and the effect it's going to have. I can't see him on the call at the moment.
He is on the call, yeah.
Fantastic.
Still trying to work out how to turn my camera on. Can you hear me?
Well, yes, we can, yes. Do you just want to sort of explain the context of the announcement in the first place, please?
Certainly. Basically, Right Care, Right Person was or is something that was developed by Humberside Police to ensure the right agency deal with health-related calls and not specifically the police. It's a process that's used alongside other nationally embedded operating models. And basically it's to ensure that the right person attends the calls, and that the police being deployed to certain calls where it'll be better and of more benefit to the person who's in crisis would have the right care they need. We're not saying that we will withdraw from all mental health related calls, certainly not. But we want to set everybody up to succeed, patients, ourselves, and our partners as well. By sending a police officer, not a medical trained professional, to those in mental health crisis, and expecting police officers to do their best in circumstances where we are not the right persons to be dealing with that patient, is letting Londoners down, is letting people of Newham down. So that's the basic gist behind it.
So can I just ask what resources the police in Newham have to support when they're attending calls involving people suffering poor mental health?
What do you mean by resources, sorry?
Or do you have anybody who is based within the police to provide mental health support? Do you have specialist areas that people can be held in, or do you literally just...
When you say held in, if someone is suffering a mental health crisis, generally there are two ways that we come across it. One is by being directed by our partners under a warrant, which we will attend with, the AMPs and medically trained persons and assist with that person's assessment, in that we are looking out for anything that may happen. And if we come across someone suffering crisis in the street, in the community, then we will obviously do what's best for that person. And if we believe they need to be taken to somewhere designated place of safety, we will do so under Section 126.
But I'm
We're not
assuming
medically trained professionals.
But I'm assuming that there'll also be other instances outside of this where you'll be dealing with people who you're aware have got mental health issues. So I'm just wondering whether there are resources based within the police to address this.
I'm not quite sure I understand what you mean, sorry.
You'll be attending to individuals, and I'm talking outside of Section 136 now, where you're sort of dealing with people who you might have been called to an incident and you become aware that that person probably has a mental health issue. What I'm asking is, are there any specialist resources that the police have access to in terms of sort of addressing that? Or if you become aware that you've arrested somebody and you're concerned about their mental health, what would happen at that point? That's what I'm asking.
If we're concerned about the mental health, they would need to be assessed. The ideal place to assess someone who we think is going through a mental health crisis is not in a custody suite. So we would take them to a place of safety and detain them there whilst they're being assessed, but that would be under 136.
Okay, I'm going to pass over to Bailey Mitchell and Michael Jones to update the Commission on the Right Care, Right Person programme, because I think one of the things I've become concerned about, because I've been in a number of meetings where this change of police policy has been mentioned, is there's been a lot of talks going on between the police and the East London Foundation Trust and our wider integrated care system about how we'll be addressing this. But what I'm not hearing is any contingency. So I'm just wondering, bearing in mind that this change is going to be happening in September, what contingencies we have in place, particularly reading the papers and seeing that apparently there's no extra funding coming down the line. Bailey, do you want to kick off, or would you rather Michael started?
I'm very happy to kick off. Thank you very much, Councillor Masters. I think, first of all, it's probably important to start with some of the discussions that have been held, predominantly at a high level within North East London between the relevant borough commanders. So there are two borough commanders covering the sort of, three places plus Waltham Forest that is most relevant to us in Newham, and chief execs of the provider trusts. And I think from what was fed back to me and to others in the senior team in Newham, is that our police colleagues very much want to work with us on this. There isn't expected to be a sudden cessation of service or a sudden cessation of police response, particularly with regard to core policing business where there's a threat to life. I think there's been a fairly sensible discussion around some of the priority areas that we can work on together. The Humberside model, which the Right Care, Right Person was based on, was achieved through that partnership and developed over a series of years. So it's not something that we're going to be able to just switch on overnight. And I think our colleagues in the police are very much committed to working on that with us. I think, I know that Michael has compiled some hopefully helpful slides which articulate some of the context and some of the detail of what we're hoping to do and achieve, and some of the context of Newham. Before I hand over to him, though, I just want to highlight some of the things that we're doing locally in partnership with police colleagues. So long before this, we've been looking at our usage of Section 136 in the borough and seeing if we can work to reduce its application by making sure that there are really robust links between crisis pathway services and our police colleagues. So at the moment, we expect police officers to ring up our crisis line, our crisis pathway, before they apply Section 136 if practicable, so that we can speak together about what the sort of possible outcomes of their contact might be, which may not be detaining someone on Section 136. It may be finding a different pathway. We've invested quite heavily in training. So a number of colleagues in our home treatment team, our crisis services, have been attending sessions at the Forest Gate Police Station, meeting with newly qualified police officers, giving them some brief mental health training, but also making sure that they understand the landscape of services in the borough, including our crisis line, which operates 24 hours a day, 7 days a week, but also our crisis cafe, which we're about to go through a process of procurement for, and also standing up crisis house bed provision, which we see as being a potential alternative to hospital admission, particularly those seen in the emergency department. And as far as I understand it, those trainings have been well received. We've also offered training to the British Transport Police, those supporting the West Ham Stadium, and we're looking to also make links with City Airport Police as well to ensure that they've got access to the same level of support and training. It's obviously in progress and being developed further. We've also identified a service user, someone who lives in the borough who has lived experience of being detained under Section 136 of the Mental Health Act, that we'd like to incorporate in that training and help to ensure that our police colleagues get a full understanding of what's available to them. And of course, we recognize the pressures that police are under and understand the motivations for this. But it is something that we have to do in partnership. The police do have a statutory role when it comes to mental health. Only they can apply 136 powers and 135 powers as well. And so we've got to work together, and I think we've got a real ambition to do that. So if Michael doesn't mind, I will pass over to him to fill in anything else you might want to hear.
Was there anything you wanted to add to that, Michael?
There wasn't, but I hope to take questions.
Okay, I'd just really like to sort of bring all our contributors in one by one and then go to questions from the panel. Antonio, you've had experience yourself of dealing with the police when I think you were in mental health crisis. Listening to what Bailey was saying, do you think they're on the right track in terms of how they're planning to sort of address this, or do you think there's more that can be done?
First and foremost, thank you for having me here to be able to contribute with my lived experience. I think the two biggest problems in the world today is one, people don't listen, and two, people don't understand. So I'm very grateful to have this space and time. Regarding your question on Bailey's comments, I think when he touched on the involvement of lived experience within that training, that was absolutely hit nail on the head, because the reason I started the campaign Hear Me Speak is to imperatively or demand that individual police forces imperatively seek the input of lived experience, because when we go from Section 136 to just Public Offences Act as well, and then to judgment, it's a very difficult and vicious cycle when you lack compassion and understanding of what a real mental health crisis feels like for that individual, and how emergency services staff may add to that stress or reduce from that stress. And there's evidence and research from Time to Change campaign, which is anti-stigma campaign, that shows emergency services staff have higher stigma of mental health than the general public because of the type of contact they have. Those incidents that they're involved in are quite high risk, intense, and timely. So inevitably their experience because they're very rarely involved in the solution of the crisis, their perspective are based off those high risk, intense experiences, and that will shape how they determine further incidents. And part of the campaign was first and foremost looking at key organizations above individual police forces. So looking at the College of Policing, the National Police Chiefs Council, and police crime and commissioners, to set the example of seeking lived experience input, because they're the ones that give guidance and training to individual police forces. I very highly doubt a police officer wakes up every morning knowing that they're going to act or intentionally and willingly act out of normal behavior during a mental health crisis. However, that then looks at reshaping the perspective and experience of those emergency services staff by including lived experience throughout guidance and training.
And is there anything concrete that you would like to see sort of change in the way that the police deal with people? I mean, if you were the person with lived experience speaking to Bailey, what would be your advice?
My advice wouldn't stray far from, again, including lived experience within that guidance and training, but I mean genuine involvement, genuine, authentic contributions where spaces are co-produced and co-led. Training needs to be complete in an atypical context that is facilitative of learning. I know that from some of the research, individual police forces rely heavily on e-learning for mental health training, and that takes away the compassion, that takes away the need to do it. Again, personally, as a student, when I'm giving any sort of e-learning material, I don't prioritize it and sort of just skip through it to as a tokenistic thing to say I've done it. So there needs to be that enforce of lived experience input from guidance and training, but it also needs to be part of legislation, because as we know, there are certain laws that need to be kept up. The culture of those laws need to be kept up, and we have done so successfully. For example, the law of the seatbelt. Most of us wear the seatbelt out of the culture of that law and the safety for us, not that it actually is law. And so that's what I mean. It's making that change and maintaining that change with the use of lived experience, because that's the only way we really come to listen and understand, as you all are doing so here with myself.
Lynn, we haven't spoken to you yet from Mind. What concerns do you have about the changes, and how do you see that impacting upon people within Newham?
I think from our side of things, I think we have concerns, particularly around sort of our racialized communities and the impact that this change would have, particularly on specific groups. So we've got concerns around that. I think there's concerns around how the police are going to discern whether an emergency mental health call is a threat to life. So what are the sort of policies, what are the procedures, how are they going to safeguard that people don't slip through the net? Will any process or systems recognise sort of cultural, racial sort of differences and nuances? So I think for us, you know, we generally have a concern about, you know, how this is going to be rolled out and what the sort of ramifications are for sort of families and individuals experiencing mental ill health, really.
Okay, so we've heard from Mind, we've heard from Antonio, and we've heard from the East London Foundation Trust as the providers of our local mental health services, and we've also heard from the police. I'm now going to sort of throw open to the Commission for questions. Councillor Laguda, you've got your hand up.
From my experience as an A&E nurse, I'm concerned about what happens when a mental health patient comes into A&E. From my experience, at times, the one patient can cause us so much mayhem that you can't even see other patients. I just wonder where, and then we used to call the police to come and help us. I'm just wondering whether that will still happen with all these changes coming into place, that you'll be able to send policemen when there is an issue in A&E with a mental health patient. Because it used to take over, the patients will take over the whole A&E. If we have to call about 10 policemen to come and take just one mental health patient. So I'm just wondering what will happen if you get all these changes, whether you still have all these policemen coming to A&E to help the nurses, because it's quite a dangerous time when a patient has got mental health and they go out of control.
I'm not sure whether that's a question to Sergeant Barry or Bailey, but if Sergeant Barry, you begin, and then Bailey or Michael can pick up. Do we still have Sergeant Barry?
Yeah. On the line.
Okay. I've noted that Simon Ashton's got his hand up actually in the meantime.
Oh, yes.
Simon, would you like to come in?
Yeah, I thought it might be helpful just to give an A&E perspective in response. So we do see some very challenging patients in our emergency department who have often quite complex needs, which include mental health and often substance abuse or misuse, and their behaviour can be at times disruptive in our emergency department. It's uncommon that we actually have to call the police to come and support us. We have, and that's because we have an enhanced security presence in our emergency departments, our own security team, and we often have registered mental health nurses in our A&E, and we're just undertaking a piece of work with East London NHS Foundation Trust and Bailey in particular, because we share a campus at Newham with the Coburn unit, so that we have a shared pool of registered mental health nurses available to work in the hospital and in our A&E, so that we can provide patients with challenging behaviour the right care at the right time. That's not to say that police don't at times come into our emergency department with patients because they've either been arrested or they have very challenging behaviours, but we seek to release the police, if appropriate, as quickly as possible and use our own resources internally in the hospital, which is an additional cost. And therefore, the work that Bailey's describing around supporting patients with mental health needs in the community is absolutely the right thing we need to do, and we need to prevent patients from reaching that crisis point, which requires a hospital admission. So we're very supportive as the acute provider with the strategy to improve mental health resources and care in the community.
And just a quick one, Simon. I mean, if you're saying you've got these security guards at the hospital, how much training do they get around mental health? Are they general security or do they have specialist training?
No, they have quite specialist training, and it's really quite sophisticated in the way in which they deal with all of our patients in the hospital. So they're well versed and very good with appropriate training.
I just want to sort of see if we've managed to unmute Sergeant Barry. Is he definitely? Okay, Sergeant Barry, are you going to come in on this particular point, or? Okay, in that case, I'm going to go to Bailey Mitchell.
He's fallen off. I'll see if he comes back.
Thanks. And also thank you to Simon for sharing his perspective. A lot of what he's mentioned, I was going to highlight. But just to add further reassurance, we work very closely with our A&E colleagues, including security there, in terms of how we respond collectively to the needs of challenging patients. And I think anecdotally, the times in which we actually need to call police in for direct support to respond to an incident there is very, very rare these days. We're often able to manage it ourselves. And obviously for those circumstances that are particularly challenging, we have options available to us in terms of trying to get them out of ED and into a safer space at the Newham Centre for Mental Health if we need to. So we'll continue to do that. And whilst we develop this enhanced care approach to having sort of more robust observations, we call it, in that setting, we do have healthcare assistants deployed in place now who can assist with supporting some of that challenging behaviour.
Can I bring Antonio in? You've got your hand up.
Thank you. I was just going to, I realized I didn't actually give a lot of context into my own experience. So if you wouldn't mind, I'd love to just summarize my experience to give some, as I said, some context.
That's fun.
Thank you. So when I was 16, I experienced my first mental health crisis. I'm diagnosed with schizophrenia and emotional unstable personality disorder. Growing up through education, I experienced a lot of pressure and expectation as a young Black man, and family culture as well and so forth. But I always strive to be the top student, and that in return turned into unhealthy pressure and expectation I put on myself. So because of that black or white thinking, I was always challenged every day, and words of encouragement were actually words of pressure to me. Ultimately, that came up to this point where I lost quite a lot of hope and just thought, the only way to get myself out of this situation was to take myself out of the world. And so there came a time where because of the stress I was also experiencing physical symptoms due to the stress I was undergoing. And that meant that I was experiencing psychogenic seizures. Back in the days, they were called pseudo seizures, but I think that's now an outdated term. And the correct term is psychogenic seizures. Now that, as I said, came from an element of stress, from the stress I was putting on myself and the stress of education and wanting to achieve and make others proud and be seen. Now, trying to deal with my seizures at the time and my mental health at the time, where I was under child adolescent mental health service and under the care of a neurologist, there was a lack of communication where my neurologist prescribed me an anti-epileptic medication. However, not knowing my mental health symptoms, that medication actually had side effects to enhance suicidal ideations. Therefore came the day where I decided to take action on my thoughts to end my own life. Now, on this day, I made my way to college as normal, and I called my child adolescent mental health service and anonymously tipped them off. However, they were able to pinpoint me through my date of birth. Now, I remember being taken out of college and being escorted back to the child adolescent mental health service office. And to cut a long story short, I was experiencing auditory hallucinations, which I felt I had to act upon. And prior to reaching that office, I had already had the plan to end my life with an instrument that I'd left my house with. Now, in that room with my psychologist, psychiatrist, and my brother, I attempted to pull out the instrument to take my own life there and then, because the voices were saying this is your only opportunity to do so. In that moment, my psychiatrist alerted emergency services staff. My brother was able to de-escalate the situation. And ultimately, the Metropolitan Police felt that they still had to continue investigations and proceed with arresting me for a fray, which in layman's term is putting the lives of others at risk. Now at this point, my psychiatrist and my brother were advocating to the police that, you know, they never felt at risk at all, and that I was the only individual they felt was at risk. And surprisingly enough, is the officer in attendance actually spoke to me very kindly and compassionately and said, you know, I can see what's going on, but unfortunately, the sergeant on the radio above me doesn't have the full picture and he's only listening to keywords. You're free to pick out your own decisions from which keywords he took from that situation. Now, being escorted to the police station, I remained in a holding cell. I can't remember for how long. That is an experience that's quite traumatic and buried in my memory. So what I do remember is then being released on no further action and being escorted to General Hospital by separate police officers. And at this point, you know, you can imagine I have a lot of frustration and resentment from the experience of being made to feel like a criminal before being offered mental health support. So I, you know, as teenagers do, come off with some attitude and mouth to the police officers. And I remember the police officer, the lady, turned around to me and said to me, well, you know, no one told you to pull out this instrument. And that was what hit me, that there was a complete lack of compassion and understanding in experiences of mental health patients. But that comes back to the first point made. I'm sorry, I can't remember who made the point, but about calling police to mental health patients in A&E. Now, as I mentioned before, emergency services staff hold a higher stigma of mental health that compared to the general public. And an important part of understanding that process is by looking at the perceptions of emergency services staff in relation to individuals with mental health problems and how they construct their views of these problems. And this is why, again, I started Hear Me Speak, not to shame or blame any individuals throughout those process, but to say you desperately and imperatively need to involve those with lived experience throughout all parts of the process, from the person who picks up, the call responder who picks up to the call related to a mental health incident, to the point of where you involve healthcare professionals. Because one thing as well I learned on this campaign is that readjusting the Mental Health Act isn't necessarily the best option, because that will just become another gateway for oppression. But in fact, can we look at why in that situation the police chose to take a public offense, Public Order Act, rather a criminal act, rather than the Mental Health Act, and how a lot of patients seep through the cracks in custody because they're actually arrested for public offences rather than Section 136, using Section 136 just to give police officers the ease of taking them to holding cells and then deciding what they do with them. Then I hope that's useful information.
That's really helpful. We always find on this committee that where we have people who can talk from lived experience, that it really brings the issues we're talking about to life. So I'd really like to thank you for your contribution. Do any other commission, Councillor Charder, you've got a question.
Thank you. And Antonio, I'd just like to echo Susan Masters and Councillor Chowdhury's comments. That must have been very difficult for you to share, and we really do appreciate it. And both to Antonio and Lynn, thank you for switching your cameras on. It makes this interaction a lot easier. What struck me was a couple of things, and I'm not sure if we've had sufficient time, Chair, but could we ask the focus on lived experience? Could we ask East London Foundation Trust and the police to share with us where lived experience works in their training programme? So maybe an outline of how lived experience is implemented in there. But my bigger points and my area of concern is, Mr. Mitchell, you were very generous in your comments towards your police colleagues, saying that they were under a pressure. Is it not also the case that the NHS is under a lot of pressure as well? And to that end, is DS Barry still on the call?
Yeah, he's back.
I don't know if you can hear us, DS Barry, but maybe you could provide a written response to this. Are you the right person to be on this scrutiny response? Because it seems to me that in that original interaction, Mr. Mitchell is presenting to us a situation where it looks all like you've all got this under control, but I'm not hearing the same from the police. So as a commissioner, I am a little bit concerned about what I'm hearing this evening. And I don't think we've really got the answers and reassurance from the police specifically about what's going to happen next. I don't know if other people feel that, but I don't feel like we've had a full answer this evening. Is Detective Sergeant Barry still on the call?
Yes,
Yeah.
I am. Yes, yes. So I'll show you the details of the right care, right person model. There are Spocks within the organisations who were present at those meetings with the Commissioner's office. I was not. Okay. So I have not been.
Sorry, I was just going to say, so in that respect, would it not have been better to field somebody who had been at those meetings to furnish this committee with the answers that it needs?
Yes, and hopefully those persons are here from the mental health trusts and the local authorities.
But from the police, you have a specific angle on this, and it's the police's response, it's the police's change and to approach that's led to this discussion this evening. It's not the East London Foundation Trust that led this, and I don't mean to sort of point this out personally, Detective Sergeant Barry, but it's the institution of the police who've led this change, not the NHS. So what I'd like is reassurance that you're going to take on board the lived experience. These issues are not going to go away. And actually, what is Newham MPS going to do, and how is it working with East London Foundation Trust? Because obviously information isn't cascading down in the way it needs to.
No, it's not. And I'm still waiting for the information myself.
Thank you.
Okay, so hopefully going forward, some of that can be shared with us. I've just got two more questions if the committee and our guests will indulge me. Firstly, one thing that really surprised me, because we were all presented with guide to your right care, right person approach. When you've got a diagram showing a breakdown of S136 usage in Newham, obviously it's well known that across the country, it's largely people from African and Caribbean communities who are overrepresented in those figures. In your figures, it seems to be the white population who are overrepresented. And I'm just wondering, I mean, this is a question to Bailey and Michael, how would you explain that? Because that's really unusual. Michael?
Hello, yes. So I have to confess the figures in the slides that was provided, that little table one, could do with a little bit further scrutiny. We looked at the data since we submitted it, looking at use of the Mental Health Act and in Newham, and it does correspond with the data from England, which is there. So formal admissions, so admissions using the Mental Health Act, we do see a disproportionate use in Black and Black British residents per 1,000 population. So that does correspond with the information seen across England. And interestingly, informal admissions, so voluntary admissions to the inpatient unit, we see a much higher proportion of white and white British residents, which I guess is suggesting that more restrictive treatment through the Mental Health Act, we're seeing higher use in Black and Black British groups, where more voluntary, less restrictive forms of treatment in our white and white British populations. And that didn't really show in the Section 136 data provided, and investigate why that is.
Okay, yeah, I thought it was strange. And the only other thing is, again, you know, when you're talking about your right care, right person strategy, you talk about it coming into place over the next 2 to 3 years. And yet the police policy is changing, even if it's not changing as drastically as we've been led to believe. It will be changing in the next couple of months, not couple of years. So what contingency is there?
Bailey, do you want me to start?
Yeah, apologies. I just had a technical difficulty and was booted out of Zoom, but I'm back in. If you've got the answer, then Michael, please do share it. But if you need to come back to me, I'm very happy to come in.
I think in terms of contingencies, as the report said, so far this financial year, there's no additional resource necessarily going into NHS mental health services. We obviously hope that will change in the future. I think I'll go back to the point already raised earlier around prevention. So at different points of the kind of urgent and emergency care pathway, we're trying to do things differently. So we rely less on the police or A&E. So making use of our crisis line and crisis assessment service, trying to strengthen our partnership with the voluntary community and faith sector through the provision of kind of out of hours sanctuaries, trying to focus more preventative and upstream. So these forms of detention and kind of more restrictive treatment aren't used in the first place. So there's kind of a variety of, I guess, mitigations we're trying to put in place across the pathway, but in terms of immediate contingencies of additional staffing, either in A&E or other parts, I don't think we've quite got to that stage yet, because we have, I guess, confidence from the conversations we've had with the Met that we don't need to yet. But Bailey, did you want to add anything?
Yeah, I would agree with everything that you've just said, Michael. And again, to sort of reiterate that point, that the assurances we've gotten is that there isn't going to be an immediate withdrawal of police resource on this date, but there is an ambition to work together. And also to earlier points made, definitely we've not figured this out completely. We've not cracked this, and the NHS is vastly under pressure. Mental health services are significantly under pressure and often underinvested in, and Newham is no exception there. And staffing is hard to find. Some of the sort of smaller areas that I guess we don't think about so much are welfare checks, about when those who go AWOL from our premises, and when we rely on help from police colleagues to try and get them back into hospital. There are all those sorts of non-emergent scenarios where we work with police colleagues to find a resolution that we're going to have to think more creatively around. There's also something around the sort of more explicit partnerships that we have already. So there's a mental health cars scheme where it's mental health clinicians who work with the London Ambulance Service to respond to mental health calls, or calls where there's an obvious mental health component. And that's one of the things that I think we as a system want to look at and understand whether it's working as effectively with police and their response to mental health incidents as it could. So there are some opportunities there too. But yeah, there will be challenges.
Okay, I'm probably going to draw this item to a close, but I've got a question for Joe in terms of the wider integrated care system. We've heard a lot about the lack of additional funding. Are you hoping that when things come to the crunch, funding will be appearing from a different route? And if not, it just, and I know it's not your fault because you're waiting on resources from above as well, but just how you expect them to be able to sort of pick up what seems like it is a rather vague amount of extra demand at this point in time.
I think that's a good question. I think anyone on this call would say that we are always hoping for extra funding. Yes, I think I don't want to commit to an answer without evidence to back it up, and I'm not necessarily the right person to do that, but I can commit to going away and coming back with a response that and working with Michael and Bailey to further understand what we can do to assist in these pressures.
So can I just check that the system will be monitoring what happens as we sort of move beyond September and just sort of picking up if there are any sort of specific issues that kind of need addressing?
Yes.
Maybe the Commission sort of can keep tabs on that as we kind of go through the year in this kind of opening section. So I'd really like to thank everybody who sort of participated in this part of the meeting. It's been really illuminating, really useful. And we will come back with some recommendations as a committee. But I'd like to, if I can now, move us on to the next item, which is looking at the NHS and executive response to the maternity services and health inequalities report, which this committee brought at the end of the last scrutiny year. So this item's basically to sort of brief the Commission on the responses of the NHS and the executive. And I'm delighted to welcome Jo Fraser-Wise, Simon Ashton. I think I've got a lot of other names here, so you have to tell me whether they're attending. Sarah Latham, Associate Director of Midwifery, Newham University Hospital. Have we got Sarah? Roger?
No, Sarah's not on the call this evening.
Okay.
My name's Shireen Nimmo. I'm the Group Director for Midwifery.
Oh, fantastic. Okay, and do we have Tris Mills as well? Because she's the other name I've got on my list.
Hi, Chair. Tris isn't available. He's the Director of Nursing at Newham University Hospital, but I'm obviously here for the hospital as well as Shireen.
Fantastic. And we've also got, I can see on screen now, Kirsten Graham, Senior Commissioning Manager, NHS North East London. And do we have Philippa Cox, who I've got down, Consultant Midwife?
Yeah, I think it stops at Kirsten.
No,
Okay,
our colleagues from the local maternity and neonatal system have been unable to attend, but Kirsten and I, along with Simon, are happy to present.
Fantastic. Okay. So is there anyone else for this item? Are there any other officers who want to contribute to this? Fantastic. So firstly, I'd just like to say a huge thank you to everybody who fed back on this item. I mean, there have been discussions with executive members outside of this meeting. The report went to Cabinet, so it's been discussed there. I'd really like to thank the hospital in particular for actually sort of working with us on refining a couple of the recommendations around the really sensitive area of charging. And I'm just wondering, just to kick off, what work's taken place since the Commission to consider maternity services completed its work?
Thank you. In your papers, you should have the response that has been undertaken. We've worked, myself and colleagues from Newham Maternity Hospital have worked with the local maternity and neonatal system, as well as our colleagues in the ICS, to really take a whole system approach to respond to the concerns that we heard from partners at the previous meeting. Broadly speaking, there's an awful lot of detail in the report, but the three main elements are that we're going to be working together to make sure that the voices of women are heard and that we understand our maternity population through really robust data collection and also through a variety of feedback mechanisms through women and through charity organisations that support our women, which we will review regularly at the North East London local maternity and neonatal system, but also at the Trust as well. We've made some really great improvements to our maternity information. We've added more accessible formats. We've got some videos being filmed across the summer, which will also be translated, and also some improvements to signposting for women to improve early access. So if people are interested, they can go onto our maternity websites and start to have a look at those. We've also spoke previously about making our direct referral pathway as simple as possible and updating that so that women can refer directly into services. That form is now live on our website. Women can translate that into their own language and send that directly into the service so that we're cutting down the time it takes for people to refer themselves in for maternity care. One of the larger pieces of work is working across the system to make sure that women who are exempt from maternity charging are not incorrectly charged. So we've been working with Maternity Action, with Sister Circle, and ensuring that they're invited to our Maternity Voices partnership meetings. We've worked with them and with our finance teams to make sure that that relationship and communication between the midwives and the finance teams has been strengthened, so that when midwives undertake the social needs assessments where we identify charging exceptions, that our finance teams are aware of that, so the incorrect charging doesn't happen. So there's, as I say, an awful lot of information in there, but Kirsten is also on the call that might want to add any more detail from an ICB point of view.
Yeah, I think just to mention the publication of the maternity equity and equality strategy by the local maternity system, and that action plan focuses on 3 main areas around engagement, around information sharing and trust, and consent. So the LMNS are working on some of the urgent actions, and they've kind of incorporated them into existing work streams so that that work can happen quickly. I think it's just worth mentioning as well that we've made some changes to our Maternity Voices partnership contract. So Healthwatch now have that contract, which I think is a really beneficial move because of the triangulation with the work that they've already done around maternity choices and the equity and equality work across North East London. And I think just to mention as well that there is a bit in the response about championing and kind of supporting our community and voluntary sector organisations, which we have done, I think, through that MVP contract. We've also managed to extend that contract for a further 2 years, taking us up to September 2026, which will really give Healthwatch enough time to sort of embed their, their plans they have around the Maternity Voices partnership. And our Parents in Mind contract has now been extended to include a Dads and Partners pilot until March 2024. And just to mention also, I think the Family Hubs work that we've been working on with the local authority, and that is also looking at utilising existing contracts with our VCF partners to expand on the kind of work that they already do around perinatal mental health, infant feeding and parent-infant relationships, to kind of ensure that that work is embedded through the Family Hub networks across the borough.
Fantastic, thanks ever so much. Have we got any questions from the committee before I sort of pile in with loads?
Me too. I'm happy.
No,
Go on. No, it's okay.
Okay, Councillor Chadha.
Chair, correct me if I'm wrong. Is this also coming back to committee at a later stage for a fuller discussion?
What will be coming back to committee will be the overseas charging report. This was one of the recommendations of the original maternity report, that we would look at that at Scrutiny, and Maternity Voices will be attending that session.
Okay, I'll leave my questions on overseas charging for that meeting then. Just a couple of quick questions. Page 48 refers to timescales on the review of standalone birthing facilities. Could we get a timescale on that, on when that review would be completed? My second question is, in terms of the work of Maternity Voices, is it possible to get a work plan? Because I've seen the Maternity Voices echoed in lots of documentation, national and local. It'd be good to understand exactly what we can expect from them so that the Commission can keep a check of what's happening as well. And just on a kind of related note, it mentions using maternity action. And I'm just curious, as if to maternity action is obviously a charity. Are they going to be reimbursed for their time and their input, or how is their work and contribution to yourselves being funded and supported? And I shall leave it there, Chair.
Who would like to come back on all those questions?
I can update you on the birth centres review. So that's been undertaken as part of a wider piece across North East London, reviewing the demand and capacity across our local area. So we're at the position now across with the Acute Provider Collaborative where we will be commissioning that review formally. So we are just seeking a business case that's got to be funded and then has to go out for procurement. So we are looking for that work to be completed towards the end of this financial year.
Thank you.
Do you have any follow-up questions, Councillor Chada?
Just on the other two questions.
Okay. Responses on the other two questions?
I can come in on the Maternity Voices Partnership work plan. As I mentioned, Healthwatch took over that contract in May this year. So we've got Julie on the call who's involved in that work, and they are working with the existing chairs at the moment to develop that work plan. So I'm sure we can bring it back to this meeting at a later date.
Thank you.
Okay, fantastic. From my point of view, I've just got a couple of questions. Recommendation 4 requests that the North East London Health and Care Partnership publicises their targets for improvements. Now, I did carefully read the responses that had come back, and I even followed the links to the documents attached, and I couldn't actually see any solid targets. Do they exist? And if so, how are they going to be monitored? Joe, I imagine that's one to you, or would anyone else like to come back on that?
I can come in again on that, Joe. Okay. I think that's one that we probably need to take back to the local maternity system, because that plan and those comments came from them. So we can take that back and provide a fuller answer on that.
What page was that?
It's recommendation 4 of the original report. And my other question was that the one recommendation that appears to have been kind of glossed over, and it's a shame that we don't have a local authority leader in the room tonight, but I will be sort of picking that up outside of the meeting. Ring-fenced funding for the voluntary sector. Now, you've just given a really good account of ongoing work with the voluntary community and faith sector. But the actual stage of ring fencing funding so that there's an understanding that that money will be there going forward, that was something that people stopped short of. And I'm just wondering how you can give the voluntary community and faith sector assurance, because that's one of the biggest worries, I think. I mean, both myself and Councillor Chada have worked in the voluntary sector, and Councillor Verdi, have you at any stage? I mean, obviously you've done a lot in the faith sector.
Well, faith and voluntary sector, but obviously in a different role.
But, you know, one of the real issues we faced in that sector was the insecurity and the fact that you're always dealing with sort of short-term funding that rarely meets sort of core costs. And I'm just wondering how you can give that ongoing assurance, and given that, you know, the plan always of the integrated care system was to introduce these new partners as you know, a meaningful part of the system, rather than people who were dealt with on an ad hoc basis. Just what work's underway to sort of ensure that that assurance takes place.
That's again, you're good with the questions. I can't speak specifically around the maternity, but if no one else can answer again, we can take that away and come back with a response. I can speak for the Newham Health and Care Partnership to say that we are currently undergoing an exercise to make sure we have voluntary faith and community sector representation on our partnership. And one of the specific areas we're looking at is for organisations that work with babies, children and young people. So I can answer from that perspective to say that's some of the work that we're doing in terms of making sure we've got those closer links and monitoring. But I will see if anyone else can answer more specifically around the maternity funding, and person has got a hand up.
I think I agree, Jo. It's a difficult question to answer. I don't know that we are able to ring fence money for them, or I'm not aware of that. What I think we do well is recognise their importance, and I think we are doing things to try and, you know, whenever there are pots of money available, for example, through the family hubs, we have looked at the VCS organisations to try and strengthen, you know, their contracts and make sure that they continue to exist in the borough, because we do value the work that they do. I think just to say that we're also bound by procurement rules as well, which sometimes restricts us in terms of contract lengths, and, you know, you can only have a contract for a certain number of years, and I know that is an area of concern for voluntary organisations, because then they can only recruit for a certain number of years, but unfortunately those are the kind of rules that we're bound by.
Okay, that might be something we come back to. And then finally, I'm not sure that recommendation 1 was understood. The point was that there appeared to be a flaw in the data around social complexity. Social complexity, I was told, reflected factors like levels of domestic violence and FGM. And for some reason, Newham was down in the information submitted as having low levels of social complexity, which baffled, I think, all of us who know the various sort of challenges that we face in Newham. And I did raise that about quality of data. And I don't think it was sort of really picked up in the response, but I'm happy to sort of take that outside of the meeting and go for a second bite of that cherry. But apart from that, it's great to hear that the forms have been improved and that support will be available for residents going forward. And we welcome your comments and the time you've taken to work this, and we look forward to looking at the overseas charging report in Scrutiny going forward. So I'd like to thank everybody who's contributed to that item and move us on to our final item. And I'm hoping that we've got the additional officers on the call, looking at air quality and health impacts. So for this item, we have Claire Greshak, Deputy Director of Public Health. Do we have Jane Custance tonight, or is she at this away day?
No, she's not there, but Nick Marks is here.
Nick Marks?
We have Nick and Leah and Nori here also.
Fantastic, brilliant. So as I explained at the beginning of the meeting, this is going to be a new area of scrutiny for our commission. And I thought, I mean, we very rarely allow presentations within scrutiny. We generally like to assume that everybody's looked at the papers and just kind of crack on with questions. But I think in this instance, because it is a new area, it's helpful just to run through the presentation and just look at the local sources of air pollution, their impact on health, LBN's work to minimise this, the rules we have to comply by, and how the committee will be able to assess the success of these going forward, and perhaps help your team in their work. So who's going to be introducing the slides in the briefing?
I'll be introducing it, Councillor Masters. Should I share my screen with the slides?
Could you? That would be great. Thank you.
Of course. Let me just.
Do you need to give Claire sharing?
Oh, that's it. Yeah, there we go. So just let me change that. There we go. So, as I suppose, very brief introduction, what we're aiming to do tonight is a relatively sort of high-level summary of the things that Councillor Masters just mentioned. So the impacts of air pollution on health, what the council does in response to air pollution. And then to finish, we're proposing bringing back some more detailed substantive items on air pollution and climate further in the year. And so that's what we'll go through. So we can take questions on what we present tonight. But what we'd also really like to do is to come back with some more detailed reports about some of the work that's going on in the council that will be at a point when we can present it more thoroughly later on in the year.
That would be brilliant. But if you can just give us that overview to introduce the Commission to this new area, that would be really helpful.
Of course, absolutely. So just to start with, what is air pollution? So air pollution refers to pollutants that are in the air that are damaging to health, and they're also damaging to the environment as well. It's a huge public health issue because it has significant impacts on people's health, and we know that it significantly impacts people disproportionately. So it's a big health inequalities issue because it tends to affect people who are more disadvantaged in other ways. So modelling in the UK has suggested that air pollution contributes to about 40,000 early deaths every year and around 5 million early deaths globally. So that's part of the sort of some of the scale we're looking at when we talk about the significance of air pollution on health and health inequalities. So what is air pollution? So it's a broad term that means can mean lots of different things. It can be particles, it can be gases, chemicals, or mold. So there's different things that count as air pollution. But what we tend to think about when in public health, when we investigate the impacts of air pollution on health, most of the research to date has focused on outdoor air pollutants, and particularly nitrogen dioxide, which is NO2, and particulate matter, which are two pollutants that are very common, and we have very good and strong evidence around their impacts. And often air pollutants go together. So if you measure high levels of one, there's likely to be high levels of others that come from the similar sources. So the way that we often describe the impacts of air pollution are broadly in two ways. So firstly, it can have short-term impacts and it can have long-term impacts. So short-term effects include things like exacerbating people's asthma, causing people to have respiratory symptoms such as coughing, wheezing, feeling out of breath. And what that can mean is it can affect anybody, but it can be particularly harmful to people that have pre-existing illnesses, particularly breathing illnesses and heart and circulatory conditions. So it can cause some people to have exacerbation of their current illness that can then lead to them becoming more unwell, potentially going to hospital. What we tend to worry about more, because the impacts are a much bigger scale and much longer term, are those long-term effects. So being exposed to air pollution over your lifetime, for all of us, increases our risk of certain conditions. And some of those include stroke, lung cancer, respiratory conditions, heart disease, and there's very strong evidence to say that the higher your exposure, somebody is exposure to air pollution over their lifetime, there's a very strong correlation with reduced life expectancy. And these effects build up over years of exposure. So this isn't the kind of effects that you'd see just through having a sort of a short-term exposure to pollution, but this is long-term build-up. The other way, so that's the first way that we think about the impacts of air pollution. The second is about how air pollution can impact people at different stages of life. So this visual, I don't know if you can see it clearly, but it's very sort of useful way of thinking through this life course impact and leading up to what I was just talking about to do with those things that can manifest in later years through a lifetime of exposure. But in pregnancy, we know that air pollution is linked to low birth weight of the child. Among children, air pollution is linked to asthma. We also know that it's linked to slower development of the lungs. So children who grow up in areas where there's high pollution tend to have smaller lungs and slower growth of the lungs. And then when you get to adults, it starts to have some of those longer term impacts. So things like heart disease, risk of stroke, risk of lung cancer. And there's emerging evidence of a link between air pollution and diabetes and dementia. And some of that evidence is slightly newer, but is starting to be quite clear about some of those links as well. So those are some of the summary of the evidence around what air pollution does to health. And I'm going to hand over now to Nick and Leah to talk through the council's duties around air pollution.
Hello, I'm a graduate trainee and I am joined by Nick Marks, who's a senior environmental control officer, who I will defer to for any technical questions. But really and truly what I'm going to be talking about is Newham's roles and responsibilities regarding air quality management. So for the most part, Newham can control and manage the vast majority of roads, set parking policy and charges. We can also enforce control of emissions through planning, anti-idling legislation and smoke control zones. And a lot of the statutory duties come from a foundational piece of legislation around the environment. So the Environment Act in 1995 requires the council to, amongst many things, review and assess air quality, declare air quality management areas, of which Newham is one, and declare and publish air quality action plans and submit annual status reports to DEFRA and the GLA. So Newham first declared its air quality management area in 2002, and the last air quality action plan was in 2019. Thank you. So there are a range of standards around air quality and the concentration of certain emissions. So for example, we have national objectives, which were set in 2010, and these are quite out of date, but Newham exceeds these objectives for nitrous oxide, specifically around the busiest roads, and the national air quality objective for that is 40 micrograms per cubic meter. So we are above that. Sorry, I'm just hearing feedback. And then, so we have regulations that were released in 2023 around particulate matter, which is PM10 and PM2.5. So they're smaller particles that are found in the air and are a lot more harmful to human health just by the nature of their them being very small. We have GLA targets, which are based on older World Health Organization targets, but these have been updated since they were set. And the latest health-based targets for released by the World Health Organization were for PM2.5, that they'd be 5 micrograms per cubic meter, PM10, 15 micrograms per cubic meter, and nitrous oxide, 10 micrograms per cubic meter. So those are considerably lower than the ones that both in Newham under the GLA targets and the wider national ones, they're a lot under that. So there's a sharp distinction between emissions and concentrations when we're talking about air quality. Emissions are what are released into the air, and concentrations are essentially what is in the air. So emissions, as you can see in Newham, a lot of them are to do with road transport, industrial processes, so like combustion practice and power and the like. And these are things that we have very limited control over. So we can only direct emissions from pollutant sources that we control, so our vehicle fleet. But what we can actually do is institute policies to encourage others to reduce their emissions. So for example, school streets, parking charges and low emission neighborhoods, and these are set out in the air quality action plan. So another thing that we can actually do is monitor the levels of pollution in our air. And the noise and pollution team provides the largest network of nitrogen oxides and particulate matter air quality monitoring of any borough in inner London. And these monitors provide the diagnostics for the project work carried out by numerous teams throughout the council. So this information is used to supplement business cases for actions such as healthy school streets and these other mitigation actions. And health impacts are definitely the driver for the work undertaken. But because air quality impacts are longer term, it is definitely clear to show that air quality improves health. Better air quality improves health. So in this map, you can see that it presents the concentrations of emissions across London. So in these images, you'll see air quality focus areas, of which there are 5 in Newham, being the A13, so the Plaster and Newham Way. You've got Canning Town, you have Stratford, and you have Barking Road and Romford Road. And as you can see, a lot of the concentrations of nitrous oxide are concentrated along major roads. So that just kind of highlights how traffic is a major source of emissions across Newham and London. Yeah. And this is a similar map that shows the annual mean nitrous oxide concentrations from 2019. And as it is further evidence, you can see that across Newham, there are relatively high levels of nitrous oxide, but particularly across the road, across roads where they exceed national limits of 40 micrograms per of nitrous oxide. So what we're really here to talk about is the strategic vision for the next year. So part of the majority of that is to continue working with other council departments to bring together the holistic nature of air quality and our action towards that, and in order to improve the health and well-being of Newham residents, workers and visitors. We also will aim to improve and continue providing publicly available data taken from our monitors, which have actually been used to provide justification for low traffic neighbourhoods and healthy school streets. We also plan to aim to implement the borough-wide smoke control order, which should be rolled out later this year, to enable the council to enforce against illegal wood burning or the sale of unauthorised fuels. And the biggest part of our work to do with air quality across this year will be refreshing the council's air quality action plan, which is due to expire in 2024. So this is just kind of to shed light on the structure of our team and kind of what we have different people doing in order to action air quality control or air quality management. So if you can see on the bottom level, we have Nick Marks, who's in this meeting right now, who is a senior environmental control officer, and Tim Baker. These are the kind of and Massimo, the technical officers who can provide a lot of information regarding monitoring and policy around air quality and other forms of pollution. And then we have engagement officers, and at the top we're headed by Jane Custance, who's the Director of Planning and Development, and Mark Partridge, who is the Noise and Pollution Team Manager. As I've kind of expressed, air quality management is definitely a holistic cross-departmental action. And as such, we have a lot of key partners and relationships. So these include, within the council, we have the planning team, environment and sustainable transport, climate action, highways, public health and education. But then we also have neighbouring boroughs that we work on. We have the GLA, we have DEFRA, the Environment Agency, TfL. We have London City Airport, which is very close to us and definitely has a considerable impact on air quality. But we also have other partners. So we have community and voluntary sector organisations. We have universities, so Imperial College, the University of East London. We have Barts Health and air quality consultants and Global Action as well. So the key projects and the forward plan of decisions for the 23-24 is that a full report is to be submitted to Scrutiny on Health, Air Quality and Climate Change. We have the publication of the 2023 Annual Status Report in May 2024. We will be refreshing the Council Air Quality Action Plan, and we're aiming for that to be adopted in the full Cabinet of 2024, so October, November. We also have the implementation of the Council's new smoke control order. We are aiming to assist highways with the implementation of low traffic neighbourhoods, continuing community energy project pilots, investigating the provision of eco moorings in Newham, the Nature Friendly School project, which provides air quality mitigations in 5 of the most polluted schools in Newham. We are also currently appointing clean air and climate champions to support our community engagement aspect of climate action and air quality action. More specifically, we'll be implementing a DEFRA air quality awareness program, introducing the Zero Carbon Schools program, as well as providing input into planning's local refresh.
Okay, Leah, I'm going to rudely interrupt you at this point because I've just noticed the time. Are the committee okay for me to extend standing orders? I only want to sort of extend them hopefully by about quarter of an hour, but if that's okay, it'd be good to have that seconded. Are you agreeable?
We might finish early.
We're still going to be finishing earlier than we usually do. Thank you. So I think in terms, I know the last bit of your presentation looks at what's coming forward and how you're going to work with Scrutiny in the future. I think that's something we can probably pick up outside. I think we've had the kind of kernel of your presentation. So I'd like to thank you for that and open the floor to the committee for any questions. Oh, sorry. Messages in the chat.
Councillor Chowdhury.
Oh, okay, Councillor Chowdhury.
Thank you, and thank you for that presentation. That was really useful. So if we had data from all of these different sources that are working on air quality, hopefully then you could target certain health interventions at residents who are particularly at risk of developing these short-term and long-term health risks. So for example, there might be that we can even pinpoint down specific residents, if not the blocks that they're living in, as residents who are particularly at risk of getting some sort of respiratory disease, and then let's say during a pandemic, targeting resources more directly to those residents. So I was wondering whether you could give me an idea, give the Commission an idea of how joined up the data is from each of these different services. So for example, we know that as councillors, we receive complaints around mould in housing. Is that centralised and shared around different air quality teams across the council? You're working with City Airport. You've got these. You're working with Transport for London. Do we know? I guess could you give me an idea of how joined up all that data is, and if it is, what kind of targeted interventions are being made, and if it's not, what are the things that are blocking that data being joined up?
Thank you. So maybe I'll start and then Nick might hand over to you if that's okay. So I think the first thing to say is there is work going on to join up data, and so there's more data join up that we could be doing and we are doing. So that will provide in sort of coming months. For example, we're joining up NHS data with council data, so we'll have a much richer data set on health outcomes and diagnoses and sort of council data such as type of tenancy and so on. So that will provide a very rich source of data. I think the other thing I would say is when it comes to targeting residents, people who are vulnerable to air pollution are also vulnerable to other things. And so it's not we wouldn't necessarily only focus on air pollution as a single issue, because people who are vulnerable to air pollution are people that have breathing problems and heart problems, which put them at risk of all sorts of other adverse health outcomes as well. So we try and look at things in that sort of more holistic way. And the other point that I would just make before I hand over to Nick about the data that we have and how we can use it is that there are two broad ways that we can protect people from air pollution. One is to reduce air pollution, and the other one is to help people avoid exposure to it. Now, the first one is by far the best approach, and the approach that as a council and as a country and globally is happening. Air pollution is improving through regulation and sort of steadily improving through sort of big shifts that we don't control ourselves in the council. So that's really where the sort of energy should be when it comes to air pollution and protecting people's health. It's much more difficult to help people avoid exposure to air pollution because we're all exposed to it all the time. So there are some simple things that people can do, such as avoid walking along a very busy traffic heavy road if they can take a quieter street, or certain certain things inside the home that can reduce air pollution or reduce exposure, but what we have much more control over as a council are those sort of actions that we can take to reduce the pollution.
Thanks, Nick. If I can just leap in, when you were sort of talking about, people taking a quieter road, one of the things that really shocked me was if you look at page 14 slide, it makes it look as though outside of our really, really key roads like Barking Road, A13, levels of air pollution are all pretty much of a muchness outside of the southeast corner of Beckton. Is that about a lack of definition in our quality of monitoring? And generally in terms of levels of promotion around the borough, how do we compare to our inner London neighbours?
Maybe I can help on that one. Effectively, the denser the population, the higher the air pollution. You'll recall the map that showed the air quality focus areas. As you look towards Tower Hamlets, you saw higher levels of pollution. And again, if you looked further out towards Barking, Dagenham and Havering, there are lower levels of air pollution. The difficulty is the atmosphere is a huge thing and it all gets mixed up. So levels of pollution are high nearest busy roads because there is a lot of traffic going down those busy roads. Get about 25 meters away from a busy road and it's down to background level, but that just means you're getting air pollution from everywhere. That's one of the problems is that the atmosphere, we have a very limited amount of control on emissions of air pollution. We, the council, produce a certain amount ourselves and can control some of the things that we do. Things like there's plans within Fleet to change over from internal combustion engines to electric power vehicles. There are things that we can do to help influence others. And I'm thinking of things like the differential car parking charges, which originally was designed to reduce carbon dioxide emissions, but will also encourage the use of more modern cars, which tend to be less polluting. Similarly, low traffic neighborhoods does show to tend to reduce. We're working with highways, we put monitors in there, and you can get a small but measurable decrease in pollution. Similarly with school streets, where they're operating, levels of pollution reduce. One of these things is air pollution. We have a strategy as a council to deal with atmospheric air pollution affecting everybody. There is also the big thing of air pollution in people's homes. And that we have almost no control over at all and no statutory duty to address it.
But hold on, Nick. We're a social landlord, and also we have the private landlord licensing scheme. Don't those two areas?
That again, and of course we are a big landlord ourselves, and whilst we can only influence private landlords, colleagues in housing are doing an awful lot in the way of improving our own housing stock. First, for the reduction of CO2, which is a key thing for the council and climate change, but also if you're reducing CO2, it's reducing combustion, which produces it, and the combustion also produces pollutants. So yes, we're doing things that we ourselves can control, but much of it we can't.
And quickly, before I sort of throw back to my commission colleagues, the slides show regulations we have to comply with, but will we be judged by what we do or the impact that those things that we do have? And what are the penalties for non-compliance?
There are no penalties for non-compliance. The legislation was derived from the EU Air Quality Directive about 1995, and the duty is on central government to achieve the standards. We were meant to achieve the standards for nitrogen dioxide by 2010, and environmental lawyers took the government to court about 5 years ago to point out that the government weren't achieving their duties, and the court agreed and required the government to make more further effort to do this. Effectively, ourselves as a council and the GLA TfL are ticking just about every box that we can to reduce air pollution both in Newham and in London. And I think the biggest change that has been is the introduction of the ULEZ in firstly the North and South Circular Road ULEZ, which has made a significant difference to air quality, and hopefully its extension further out if it survives the legal challenge currently in front of the High Court.
Can we have that data shared with us? Because I always feel with ULEZ that there's a lot of talk about it improving air quality, but we never actually see the hard data of the difference that it's made to people's lives. So that'd be really helpful.
We can get ULEZ data.
Okay, I've seen Councillor Chowdhury. I'm assuming that's new hands.
Yes.
I'll just check with my two colleagues because they haven't come in yet. Councillor Chowdhury, have you got a question?
Yes.
Two. Okay. If I throw to Councillor Chowdhury first, Councillor Verdi, you had a question, didn't you, about the data? So I'll go to you and then to Rick. But if we can keep the answers quite short, we want to let you all go home. What's a relatively early time for health scrutiny? So Councillor Chowdhury, your questions.
I'll give way to Councillor Verdi.
Honestly, it really doesn't.
And well, mine will hopefully be brief. So can the officer just confirm to me that in the corporate plan, the air quality action plan is the KPIs for the corporate plan on air quality are the ones related to the 2019 action plan at the moment? Is that right?
I'm afraid I don't know what in the details of the corporate plan. The Air Quality Action Plan is a statutory document required by the Environment Act. That's what I and the team and colleagues within other council departments are working towards.
Would it be possible for somebody to find out what the KPIs for air quality are? Do we set our own KPIs as a council?
I'm not aware of any.
Do we have any through the 50 steps though, Claire?
We don't have KPIs on levels of air pollution. I suspect as a council we wouldn't set our own KPIs because it's an incredibly technical, sort of scientific area, and we probably as a council would be best following. Nick's got his hand up, so he'll be able to give a better response. So, so in summary, we definitely don't have any in the 50 steps, and I suspect as a council we don't set our own KPIs around pollution.
Okay, Nick.
Yeah, if you're looking for the difficulty is with air pollution is that the levers the council has to control air pollution in atmospheric air are very limited indeed. We can get a measurable decrease in very specific areas, and I do, with things like the low emission neighbourhoods and the school streets, and I'm pleasantly surprised we do, but they are very small decreases considering the universal amount of air pollution. Almost none of it we as the council have control over.
Okay.
Yeah, just one other question. In terms of what can we do to help our colleagues on strategic development? Because every summer there's lots of complaints about developments, especially last summer, and pollution rising because of the regeneration in the area. Do you proactively look at those developments again once they've had planning permission to check what the pollution levels are? How do we monitor developments in the area in relation to pollution?
That we, the pollution team, don't. It's down to the if there are planning conditions placed on there, and certainly for major developments, we do recommend planning conditions which are compliant with both Newham and GLA's policy on air quality.
Yeah, but we don't.
But who monitors them then?
We don't monitor them.
So we don't monitor them at all.
There's not an earthly chance of getting that done in the current resources.
So are we reliant on residents then to report when pollution is too high at developments?
What we would look at is, are they complying with the planning conditions that was set on when a development consent was given? Whilst we may be able to, the pollution team may be able to provide a certain amount of small technical input, it would have to be led by development controls enforcement team, because it's a planning condition and it's not something the pollution control can enforce.
Okay, I mean, I think we need to ask a question of the development control team outside of this meeting in that case. Councillor Verdi.
Yeah, Chair, I must declare interest, obviously, because I'm the planning committee anyway.
Of course, yeah.
Right? So I have to be mindful of the questions which are asked, which I won't ask now because of the issue. But my question just goes back to page 11. Right, we've got a document which shows us from 2019. We're 4 years down the road, in a sense, and picking up on what Iraq said as well about the mold. We have lots of houses. We are big social landlord ourselves. And if we are saying mold has a key part to play in the health of the children and the families, why aren't we doing something significant? That is the question that needs to be answered, because to the people who are against the ULIS, right, cars are an easy target, where mold is something which can't be seen by somebody from the outside. It's only the resident that suffers. So we need to have an action plan of how we're going to take this forward for the future. I'll leave you there.
Is this more of a question for housing, who we will be having to help scrutiny at some point?
Solution as well.
Will it be in the action plan?
That the action plan has to follow a format set out by the GLA and follow the requirements of the Environment Act. The Environment Act specifically refers to ambient air, that is air out in the general environment and not air in homes.
Okay,
so
sounds like
it won't be including action on mold in the air quality action plan.
Okay.
Claire. Very, very briefly to say that we totally recognise the issue of mould and damp as a public health issue. The two are very linked. And as we mentioned, you know, mold can be considered an air pollutant, but there is separate work going on around that. So it would be, if we wanted to explore that specific issue more, I'd recommend that we have colleagues like Councillor Masters mentioned from housing and others who are more involved in that side of the work.
We will be having that at a future meeting, because one of the things I really wanted to pick up this year after things that came up last year was the relationship between housing and public health and the wider infrastructure. Councillor Chowdhury, I think you're going to have the last bite here.
Firstly, just totally echo that Councillor Verdi's question about mould. I really think it should be part of the quality initiatives. My question, going back to my original question. So the reason I asked it was thinking about the pandemic. We had this priority list for vaccines, which I think basically was done by age. So it's like from 80 years plus, and then they were the first to get the vaccine, and 70 years plus, they were the next cohort, etc., etc., etc. I wonder how much was data that's locally collected shared with central government for things like vaccine rollouts. It could have been done in a different way, where actually we know that certain areas are more prone to having higher levels of air pollution and therefore higher risks of respiratory conditions, higher risk of catching COVID and suffering from COVID. And I wonder whether in a future pandemic that's actually a lesson that the council could be providing to the COVID inquiry or any future inquiries around pandemic preparation, to say actually we should target vaccine rollouts or mask deployments or whatever other intervention it might be, based on likelihood of being harmed by it based on this data that we have. So I wonder, the question is, how much is it shared with central government at the moment?
So a few points on that. Firstly, the data that we have on health outcomes is NHS data primarily, and so data is aggregated and shared from different parts of the NHS to different levels. So there is a national picture of health in the UK. We look at it at a very granular level in Newham. I don't imagine central government look at it at that level of granularity, but the data is there in the NHS to look at in terms of people's health. One of the challenges that we picked up before was about the linkage. So locally in Newham and in North East London, we're doing really, really good work on linking up health data with council data. So that's a huge, I think, something that we can be really proud of and that can really help us move forward in Newham. The point about preparedness and using data to target interventions is definitely something that we do already, but we can do more. Whether we do that locally or whether we share our sort of our learning and our experience with central government or with other partners, we can definitely do more of that. In terms of the vaccine specifically, that's a slightly different one, because the cohorts for prioritisation were based on COVID outcomes. So there was a clear prioritisation based on those at highest risk of death, and it was sort of age primarily, and then there were some cohorts that included long-term conditions in there as well. So it wasn't quite the same as looking at the risk factors. It was more around the kind of the data on the actual outcome from the infection. So that's slightly different, but I completely agree with the point.
Okay, I think there's a lot to discuss going forward. Outside of the meeting, I'll sort of establish what particular documents are coming forward in the coming year, and then we can definitely have you back to scrutiny, possibly when we have housing in the room as well, because that seems like it would make sense. But I'd really like to thank Claire, Leah, Noor, Nick, and I see Julie Powell's still on the call as well. So thank you, Julie, for hanging around for the whole meeting, and Joe as well, you too, because you've had quite a long meeting. So I'd just like to finish by giving a special, very big vote of thanks to our officer, Roger Raymond. This is his final meeting as a Newham Council officer, and I'm sure we'd all like to wish him well for the future. And finally, the date of the next meeting of the Commission will be on the 21st of September 2023. I'd like to thank everyone for attending and wish you all a wonderful summer. Oh, Charlotte, you've got your hand up. Did you want to add anything, or is that a historic hand?
Apologies, that was me clapping for Roger.
Okay, fantastic. So
thanks, Roger.
wish you all a wonderful summer, and we'll see most of you in September, I hope. Thank you. Good night. This concludes the public business of the meeting. I now declare the meeting closed at